Hey guys, Tony here. In this video, I want to share a really interesting story. So the purpose of this channel, the goal for me in bringing you guys this information is to really give you a peek behind the curtain. I want to show you guys the stuff that maybe you don't get exposed to, the information, the thoughts, the ideas, the questions we have as physical therapists and rehab, specifically for patients who are dealing with and recovering from total knee replacements. I want you guys to see behind the scenes. And this is a really interesting case that I want to share with you today. So I'm changing the name, I'm changing gender, I'm changing some details just to protect patient privacy. But I think somebody is about to have a knee replacement that shouldn't have a knee replacement. And worst off, it's not going to achieve the goals that she's looking for. So let me give you some context and some background. If you're not interested in hearing the story, go look at my other videos on this channel, find some exercises, find the stuff that you came here looking for. But this is kind of an interesting case. So I've been treating a patient. She was originally referred to me before the COVID crisis in the US. We had been working together about a month to 6 weeks. The original referral was for right knee pain. Now this is going to become important down the road. So she comes to me with a referral for right knee pain. Just to give you a little context and history, the individual was doing phenomenal when it comes to function. She was going to a local fitness center, working out 3 to 4 days a week. She travels everywhere with her husband. She's 84 years old. You would never know it in a million years. I was totally shocked to find her age. She lives independently in the community. She walks without any kind of assistive device. She had a personal trainer that she was working with. You know, she doesn't have any real medical complexities. She's not diabetic. She's not hypertensive. She doesn't have the normal stuff that we deal with as adults. She wasn't overweight. She wasn't deconditioned, you know, so she was doing really well. Now, she did have a past surgical history of having both hips replaced at different times. One was a little complicated, one went really well. Now, the complicated hip replacement was on the right, which is where she's experienced knee pain. For those of you that know a little bit from a clinical perspective, when she showed up in my clinic and I saw her walking into the clinic, the first thing that stood out to me was she had a significant valgus curvature to her right knee. So the knee basically was collapsing in, if you think of it as like a person who's knock-kneed, but it's just on the right side. She didn't have full knee extension on the right. She was a little bit limited and she was limping a little bit. Now, but all of that being said, her chief complaint, the reason why she came to therapy was because she had fallen twice within the past month at the fitness center while she was working out and walking around the track. She was complaining of knee pain, and this is going to be important. So she comes in and we sit down and we have a wonderful conversation. I'm talking to her husband. They're filling me in on everything. And, you know, my normal, just so you know what an experience is like, I usually sit down and spend 15, 20 minutes talking to get a sense for who this person is, what's important to you, what are the problems you're having. And I want to get a sense for the history. You know, when did this start? How's it changed? What's better? What's worse? What makes your symptoms increase or decrease? What else have you tried? And then right away, I like to get moving, because it's one thing for me to hear what you as the client are telling me, but it's another thing for me to see you move. Because at the end of the day, I've been doing this 20 years. I've had the great opportunity to see hundreds and hundreds of people move, whereas, you know, most of my clients are not educated in the body and orthopedics and all of that. So I don't expect them to really recognize or see things that I may be able to see because of my experience. So we get up, we go out into the gym, I'm watching her walk around, we start doing some exercises, and pretty quickly we can see, you know, there are some deficits here. She's limping, she's got that altered walking pattern, altered gait because of the right knee valgus, because of the lack of knee extension. There's a couple other things going on, but to me what stood out most predominantly was the fact that she stepped and walked very tentatively. She was not able to just get up and go. She had to stand up, she had to stop, kind of steady herself a little bit, and then she would begin walking. And usually there's something going on there, either, weakness or pain or desensitization. She's not maybe a neuropathy or something like that. And so, okay, so we start going through our workouts and we develop a treatment program specific to the right knee pain, and I'm palpating and figuring everything out. But her symptoms really weren't consistent with an osteoarthritis kind of knee pain. The meniscus, the cartilage that covers the ends of the bones, those really didn't seem to be the problem. And what I find most revealing is how the symptoms come and go. If you come in on Monday and you tell me that your knee is miserable, it's inflamed, it's so painful, it's swollen, and then on Tuesday, you're doing great, and then on Wednesday, it's painful again, to me, that's not really consistent with a true mechanical problem. That tends to be what I would consider more of a chemical problem. Now, there's probably mechanical problems there. I'm not doubting that there's osteoarthritis and the things that we typically hear about a knee that needs replaced. But the question is, why do the symptoms change so abruptly? Why do they vary so wildly without changes in activity levels, without changes in, diet and other factors? How does it change day to day if it's a mechanical problem? Mechanical problem is persistent. The arthritis doesn't go away. The arthritis is still there. So it's a chemical problem that's maybe a contributing factor to the symptoms you're experiencing. Okay. But now the second part of this is, so we're going through the workouts and she is just doing amazing. She's blowing my mind. Like, we do certain exercises, something called a suitcase carry. I'm sure you can imagine what that's like. You have a weight in one hand, no weight in the other, and you get up and you walk. This little lady, I'm guessing, but I'm going to say she's, I'm 5'7", she's probably 5'4". She probably weighs 110 pounds. She's carrying a 20-pound kettlebell in one hand. She's able to go from sitting to standing without pushing off, carrying this kettlebell, walk 50 feet and sit back down. No pain, no problem, no dysfunction. She's not walking well, but it's not because of pain. It's because of the sensation and the lack of control in the lower extremity. And she's doing exercises like I do this one where you can't see it here, but I have think of a workout bench. You would sit on the workout bench, you'd lay back, you would sit up and stand. Sit, lay, sit, stand. Pretty basic exercise. And then I would include like get up and go. We would do that. No problem. She was unsteady, but not pain. She was able to transition from standing to kneeling to laying on her back on the floor and then get back up. No pain. Dysfunction, pathology, but no pain. And the knee wasn't unstable. The knee was intact. There was never a point where the knee buckled because there was an instability. And so you see the picture I'm painting, right? Like, she was a very high functioning individual. I'm envious. I want to be in her position at age 84. I really do. So she's getting frustrated though, because she is experiencing pain, not during exercise, not during daily activity. She's experiencing pain at night. And when the pain comes in at night, the way she describes it, one of my common questions is, can you take one finger, put the point of that finger on the point of the pain? And, so many times, like, pretend this is my knee here. Let me see if I can get it. Pretend that's my knee. And I'll say, can you put one finger on the point of pain? They're like, well, it's kind of all around here. And that's what we were finding, was that when she really focused on trying to localize the pain wasn't in just one area. It wasn't just at the meniscus. It wasn't just at the patellar or patellar tendon. It was really more in the thigh musculature, the connective tissue above the kneecap. There was pain below the knee into the calf and the side of the leg. And so one of the problems that I witness, I'm really fortunate. This is my practice. I'm the practice owner. I get a lot of flexibility in my schedule. And because of that, I'm able to attend a lot of patient follow-up visits with their physicians, with their surgeons. And one of the things that I've noticed over the last almost 20 years is there is a major disconnect between what the patient is saying and what the surgeon is hearing. And the disconnect goes both ways, because then the surgeon will say something and the patient will hear something completely different. And as a third-party observer, I'm able to see this interaction. And so what I'm fearful of that's happening in this case is the patient is going in and telling the doctor, my knee hurts. And the doctor is looking at the mechanics of the knee and saying, well, clearly there's degenerative changes. The knee is in a valgus position. Let's order an MRI. And the problem with the MRI is I have no doubt the MRI is going to show degenerative changes in the knee. And when you combine the degenerative changes that show up on an MRI with the patient complaint of pain in my knee, the natural kind of 1 + 1 = 2 response is, okay, let's get a knee replacement. But there's so many other factors that aren't coming into play. First, when the patient says, my knee hurts, the surgeon is hearing, well, the ends of the femur, the ends of the tibia, the space between the two bone surfaces, the cartilage that covers the bone ends, the meniscus. That's what we hear when we think of knee. We think of the anatomical knee itself. But to the patient, because I've had this conversation, the patient says, my knee hurts. That can be anything from below the hip to above the ankle. And there is a lot of real estate below the hip and above the ankle, right? So this is the lack of communication that I see consistently, and it's nobody's fault. It's just, this is what happens. And we're busy, and the patient's nervous in the doctor's office, and they're not necessarily thinking about everything that they want to get covered. The doctor has obviously other responsibilities and is trying to extract the information to the best of the doctor's ability. But without a translator in there, hence that's why I go, certain details tend to get lost, right? So this patient isn't telling the doctor, hey, I can get up off the floor without pain, but my leg, not my knee, my leg hurts at night. The patient didn't say, hey, I can carry a 20-pound kettlebell in one hand and walk 50 feet. I can go up and down the stairs pain-free, but at night my leg hurts. And so this patient, I believe, is in a situation where you've got lots of disconnected providers who are trying to help. Now, I do the best that I can. Obviously, I'm in communication with the physician. We're super lucky. This is an amazing physician she's seeing. He's a non-surgical orthopedic. So it's not even like he has a vested interest to say, well, let's go get a knee replacement because I want to buy a new pool. He has no financial benefit in her getting the knee replacement. He wants to help her to the best of his ability, and we all do. And I think that everybody is trying to do the right thing and make the right choice, but nobody is getting the full picture. And if I haven't said this already, I don't think that I see something that somebody else doesn't. I'm certainly not smarter than anybody else, but I am afforded the benefit of spending an hour, 3 days a week with this individual, oftentimes for several months. And so if you think of my 18 to 24 hours, one-on-one, fully focused on this individual, hearing every detail about their life, and how did you do getting in and out of the car, and how did you do, going up and down the stairs and walking down, sorry guys, walking down through everything. That's where the real value of physical therapy comes in, and I think that is where we get lost a little bit in the medical system, is most professionals just don't have the time. So, okay, you've heard this novel of a story. Now what? Now what do we do? Where do we go from here? So she and I have been talking over the last couple sessions. The way she left it with the physician was that they were going to order an MRI and they were going to investigate, maybe refer out for a consultation with a surgeon. I said, well, let's just talk about the other factors that you have to consider, because I'm certainly not talking you out of surgery. But on the flip side, you are 84. You do live with your husband. There is no local family. Are you prepared to go to a skilled nursing facility? Because truthfully, I'm not sure that your husband would be able to care for you at home. He has his own medical problems. He's hard of hearing and other things. And she said, well, no, I don't think I could leave my husband at home alone for 3 days or a week or something like that. Okay, so that's something to consider. If you go home Are you comfortable with home health therapy coming into the home? Nursing and occupational therapy and all of this. Well, I don't really like having people in my home and I'm uncomfortable with that. Can I just come to outpatient? In an ideal world, you absolutely can come straight to outpatient, but we don't know. We don't know if there's going to be an infection, a complication, a blood clot, if there's problems with the incision healing. She did really well after the hip replacement, but she went to a skilled nursing facility, and this was many years ago when both she and her husband were younger, healthier, more fit. And she didn't like the skilled nursing facility. She asked to be discharged probably a little prematurely. So, these are other factors. And now, of course, we have to consider exposure for you from other people coming in that are going into other homes and treating other patients. There's so many factors here. And then we have to look at, okay, so I asked her point blank. I said, when is your pain the most intense? Well, it's at night when I'm trying to go to bed. It wakes me up at night. Okay. When is your pain the least? Well, during the day when I'm moving around once I get warmed up in the morning, I can go all day. I don't stop. But then when I get home at night, now the pain starts to kick in and it's worse in bed. So maybe there are other things going on. And I really believe, truthfully, like after all of this long story that I shared with you guys, I think when I watch her and I've seen her lose her balance, I've seen her stumble, her symptoms to me as a therapist present more like a complication of the neuropathy. It's a non-diabetic peripheral neuropathy. I feel that she cannot feel the ground as well as she wants to. And when she's losing her balance, I've seen her recognize in her eyes that she's losing her balance and then respond, but it's a delayed response. The brain knows what to do, but the nerves aren't carrying the signal out to the muscles quick enough. And so I feel like this is a situation where this individual would have a knee replacement. Everybody would be doing the best that they could do, the best intentions, but it's not solving the problem. And the reason why is because every part of the healthcare system is just so disconnected. So the goal in me sharing this experience with you guys is not in any way, shape, or form to talk you out of a procedure you're going to have. But it's to share an experience that somebody is dealing with right now and to acknowledge the fact that, look, I am a therapist. I work hard at what I do, and I can't say that I have the answer. I can't tell you not to have the surgery. I can't tell you to have the surgery. I have no idea. I trust the surgeons. I want to go by what the surgeon and the physicians and everybody is advising, but I want the patient to have as much information and take into account every aspect of this decision, not just, well, my knee hurts, there's degenerative changes on imaging, I think this is the best option. The truth is, there might not be an option. The truth is, she might decide, hey, I'm 84, I don't know how many more years I have, hopefully I have more than 15 or 20, but I don't want to spend 3 months, 6 months, a year in miserable pain, going through the rehab process, losing my mobility, losing all this stuff. I'd rather deal with the experience and the symptoms that I have now and work into the future on staying as healthy as I can get, as strong as I can get, and continuing to make the most of my time as it is right now. But she might also say, hey, this is the best thing, this is what my doctors say, this is what I'm going to get done, and she could do phenomenal. There is no wrong answer. Guys, I hope this story was interesting to you. I hope that maybe you can relate, or you know somebody who can relate. If you do, share this video, see what other people say, post in the comments. Does this resonate with you in any way? Do you like to hear this kind of stuff? I mean, I know this patient isn't you, but there's going to be a handful of you that are like, hey, that sounds exactly like what's going on for me. My goal isn't to advise. This is not medical advice or telling you what to do. My goal is to expose you to the questions and the ideas and everything that's going on in the therapist's head, because I'm a therapist and this is my head. Guys, thank you so much for watching. I'll catch you on the next video.